Good evening. We'd like to welcome everyone to the Pheo Para Awareness Week webinar, hosted by the American Association of Endocrine Surgeons and in partnership with Pheo Para Alliance. I am Sara Cartwright with the University of Nebraska Medical Center, and I'm one of tonight's moderators.
Hello, I am Dr. Jennifer Rosen. I am the Regional Chief for Endocrine Surgery at MedStar, Georgetown, Washington Hospital Center, and I'm the other moderator for tonight's webinar. We've assembled an amazing expert panel to answer your questions tonight about Theochromocytoma and Paraganglioma. Tonight's webinar is being recorded, will be made available on the AAES Facebook page and on the AAES YouTube channel. We will be taking live questions from the audience this evening. You can enter your questions in the comments section directly on the Facebook live stream. Please be aware that we will not be answering any personal medical questions or providing specific medical advice, but we'll do our best to answer questions. For those kind of questions or requests, ask for advice from your doctor or medical team.
We'll start by introducing and getting to know our panelists in alphabetical order. We will start with Dr. Jimenez.
Good evening, everybody, and thank you very much for this invitation. I am Camilo Jimenez. I am professor of endocrine cancer and hormonal disorders, and I work at the University of Texas MD Anderson Cancer Center. I'm currently the head of the Theochromocytoma and Paragongliomas program there. And over there, my main interest in research is focused on the development of systemic therapies for patients with metastatic disease. I also work as the chair of Diversity, Inclusion, and Equality at the North American Neuroendocrine Tumor Society, and I am one of the members of the scientific board of the Pheo Para Alliance. Thank you.
Next, Dr. Lyden.
Hi, everyone. My name is Melanie Lyden. I am an endocrine surgeon and professor of surgery at Mayo Clinic in Rochester. We have a very busy endocrine practice with 4 endocrine surgeons. We do a lot of adrenal surgery and paraganglioma surgery, and we really work on practicing in an individualized manner. As you know, it's a very unique practice with the endocrine disorders, and I'm very pleased to be here, and we really appreciate you being there and are looking forward to answering your questions.
Next, Dr. Miller.
Good evening. My name is Barbra Miller. I'm one of the endocrine surgeons at The Ohio State University in Columbus, Ohio. I'm the co-director of the Comprehensive Adrenal Program. I also serve as the secretary for the American Association of Endocrine Surgeons and serve on the executive council for the International Association of Endocrine Surgeons. So it's nice to be here with everybody tonight.
And Dr. Nehs.
Hi, everyone. Good evening. My name is Dr. Matthew Nehs. I work at Brigham and Women's Hospital and Harvard Medical School, where I'm an assistant professor of surgery. I'm also the surgical director of our adrenal center. We have a very high volume adrenal and paraganglioma center where I operate on abdominal paragangliomas and head and neck paragangliomas as well. I really look forward to chatting with you this evening.
Great. So thank you to all of our panelists and our moderators and for all of you for joining us. We're going to start by answering your questions. We also prepared a few patients, interesting patients to discuss, but we'd be very interested in hearing your questions. As a reminder, again, we're not answering any personal medical questions, providing specific medical advice during the webinar today, but if you can phrase your questions as a general question, we'd be happy to try and address it. So let's see what we've got with Emily Williams' assistance in our chat box. So I'm going to open our chat up right now, and we are live. Well, to get started, Dr. Cartwright, do you want to take us through some questions that were submitted in advance?
Yes. So first question, what are treatment options for metastatic Pheo with liver mets? And is surgery ever indicated in this situation? I'll let anybody want to start out with this one.
I can start from the systemic therapy perspective. So I can tell you, when you have someone with metastatic pheochromocytoma, you may wonder what kind of therapies you may have in clinical practice. And many times you wonder if there is really a therapeutic evidence that could be effective for the treatment of the disease. So there are some good news. And the first good news is coming from the fact that in 2019, in the United States, the first medication was approved for the treatment of metastatic pheochromocytomas and paragangliomas by the FDA. That medication is called high specific activity MIBG. This is a medication that works as a radiopharmaceutical agent and is quite effective for patients who have metastatic pheochromocytomas that express the noradrenaline transporter. The meaning of expression of the noradrenaline transporter is simply that the tumor is visible in an MIBG scan. This is a medication that works in approximately 92% of patients. It is mainly characterized by a stabilization of the disease, although you may see some substantial reductions of the tumor size in about 24-25% of individuals. And the medication works slowly but progressively, improving the stabilization of the tumor, decreasing the size of the tumor, decreasing the hormonal activity in case the tumor is hormonally active, and improving the quality of life of the patient. And in many patients, the responses could be long-lasting responses. You may see patients who may respond to therapy for 5, 6, 7 years and continue in time. So this is an effective medication. There are other treatments that we have as systemic therapeutic options. They are mainly in clinical trials. I am excited about a new medication that is called Belceutifun, medication that is FDA approved for the treatment of von Hippel-Lindau disease-related tumors, such as kidney cancer, pancreatic neuroendocrine tumors, and others. And this medication is currently evaluated in a phase 2 clinical trial for patients with metastatic pheochromocytomas and paragangliomas. Although I cannot share with you any results yet, I think that this medication could be quite effective as it targets the core or the heart of many metastatic pheochromocytomas, such as the hypoxia-inducible factor 2 alpha, which is very important, especially for those tumors that are associated with Sdh mutations, which are frequently associated with a metastatic phenotype or metastatic presentation. We also have medications such as tyrosine kinase inhibitors, in this case, cabozantinib or sunitinib are medications evaluated in clinical trials so far with very positive results, similar to high specific activity MIBG. They are able to stabilize the disease for some time. They are able to decrease the size of the tumor. They may decrease the production of catecholamines in case the tumor is hormonally active. And of course, they may be associated with an improvement of the symptoms that the patient may have. And yes, from the very old times, you may still have chemotherapy as an option. This is usually a combination of cyclophosphamide, vincristine, and dacarbazine. And this group of medications together may provide you with positive responses in approximately 25 to 35% of patients. It is difficult to predict, however, which patients may respond to chemotherapy. That in regards to systemic therapy. In regards to surgery, of course, I will leave this on my endocrine surgeon colleagues to answer to that part of the question. And I can add at the end some of the experience that we have in that perspective as well.
There's so much content to what you just said. Every single one of the things that you just said, there's just so much rich content there. I'm going to make things, we got a couple of questions from Facebook that we're going to take us back to the beginning a little bit. So, and then we're going to make it through to what you said really, which is going to be important for a lot of the people who join us here, who I'm guessing many of the people who joined us today and are part of the Pheo Para Alliance are thinking about their children, thinking about their families, thinking about the early stage management. One question I'm going to put to Barb Miller. Dr. Miller, what does pheochromocytoma actually mean? How do you know if a patient has a pheochromocytoma to begin with?
Well, that's a long question. So pheochromocytoma and paraganglioma, we might as well kind of start there and differentiate between the two. And essentially, pheochromocytoma is excessive adrenaline production in a couple of different forms: epinephrine, norepinephrine, dopamine rarely. And that originates from the center of the adrenal gland. The adrenal glands are two paired structures that sit above the kidney, way in the back of the abdomen, behind the liver on the right side, and behind the stomach, the pancreas, and the spleen on the left side. And so the adrenal is surrounded on the outside by what we call a cortex that produces a number of different hormones. And then in the center, there are some cells that produce what we call catecholamines, which is, I'll just call it adrenaline. And so when we talk about paragangliomas, those are extra adrenal adrenaline producing tumors. And those generally are anywhere from all the way up by the skull base, down the neck, down the spine, through the chest and the abdomen, and including in the bladder sometimes. And so we may talk about those a little bit later. I know on the Pheo Para site today, there were some discussions about paragangliomas in the thorax and also in the bladder. So those were interesting to watch. You know, when you're trying to determine whether or not you have a pheochromocytoma, I would say that, you know, probably about 40% of these are discovered incidentally, 40% have classic symptoms, 10% are determined by genetics, and then you have another 10% that present in crisis, where they're in the hospital and they have hypertensive crisis. So, you know, it can be a very difficult diagnosis to make because high blood pressure is the most common thing, palpitations, some anxiety, sometimes headaches. Those are all very, very common things that people experience. And because pheochromocytomas and paragangliomas are very rare, the incidence is about 2 to 8 per million in the population. So it's a very rare disease, as many people know out there who are watching this. So it's not the highest diagnosis on a doctor's list, especially your primary care physician. So sometimes when we see people in the office, we say, oh, it's kind of a no-brainer, you have a Pheo, right? Well, those patients had to go through a lot to get to us. And I know that's frustrating for some patients out there where it takes a long time to get your doctor to listen to you and to listen about your symptoms. But there are a lot of other things that are much more common that we have to kind of go through and check the boxes and say, nope, it's not this, we need to keep going. And so because a lot of patients present to their doctors with other symptoms, they end up getting CT scans or some sort of imaging that may identify a tumor in the adrenal gland, and that kind of sets us down that path. Or they have lab testing that's done because somebody is fairly astute and kind of picks up on something. So there's different ways to get to this diagnosis, but ultimately it is a biochemical test. And I can let Dr. Jimenez talk about that as well, if he would like to.
So biochemical testing is quite important for pheochromocytomas and paragangliomas. If you follow the principles of endocrinology, whenever we try to make the diagnosis of an endocrine disease, we have to start with the biochemical testing once you have a clinical suspicion. And once you have biochemical suspicion, then you proceed with radiographic studies. Now, in the case of pheochromocytomas and sympathetic paragangliomas, the measurement of the plasma metanephrines or the 24-hour urinary fractionated metanephrines are considered the most important tests in clinical practice to diagnose or to rule out the presence of any of these tumors. The reason is simple. They are quite sensitive studies in clinical practice. For instance, the plasma metanephrines offer a sensitivity of 99%. In other words, they are able to identify 99% of patients who have pheochromocytomas or sympathetic paragangliomas whenever they are hormonally active. And the sensitivity of the 24-hour urinary fractionated metanephrines is 97%. In clinical practice, you may choose whichever of these two different tests to do. You may do plasma metanephrines, you may do the 24-hour urinary fractionated metanephrines. It's up to you, the election of any of the two different tests. In our
Dr. Jimenez,
we do plasma metanephrines.
I'm going to interrupt and ask you a question, which is, so if I understand a little more simply what you mean, is that if your blood test is positive, you still need to do the urine test. And if the urine test is positive, how do you know if somebody has it? If somebody has all the symptoms of a pheochromocytoma, but their plasma test is normal and their blood test is normal and their urine test is normal, what does that mean?
Very important question. So no, you only need to do one of the tests. You either do the plasma metanephrines or the 24-hour urinary fractionated metanephrines. So in the practice that we currently have in the US, and if you follow what, for instance, the American Association of Endocrine Surgeon guidelines recently published suggests, is simply that we can do either of one of the two tests. Whatever you prefer in clinical practice is up to you. The plasma metanephrines offer a higher sensitivity than the 24-hour urinary fractionated metanephrines, but the urinary fractionated metanephrines is also an excellent test. For instance, in many different countries, you are not still able to measure the plasma metanephrines. Therefore, in those countries, what mainly doctors do is to measure the 24-hour urinary fractionated metanephrines. Now, let's say that the plasma metanephrines or the 24-hour urinary fractionated metanephrines are normal, but the patient has several symptoms that are consistent with pheochromocytoma and paraganglioma. The likelihood that that patient has a pheochromocytoma or a sympathetic paraganglioma is very low. The plasma metanephrines are made to rule out the presence or the absence of a pheochromocytoma or sympathetic paraganglioma with a very, very high quality.
Dr. Lyden, could you talk a little bit about the pre-surgical workup?
Yeah, from a surgical standpoint, the most important thing, aside from confirming the diagnosis, is the localization. And most often, these are found many times on a CT scan. The MRI test can be very specific. And in patients that, that have these, there can be a risk of malignancy too. So many times we'll also obtain a dotatate scan, which is a nuclear medicine scan that can look at the whole body and help localize it, versus many CT scans or MRI are focused, primarily on the abdomen or in the chest, in those areas.
We do have a specific question about dotatate scans that came in before we started. So maybe this would be an okay time to touch on that. The question is, if there is activity on a dotatate scan in a distant location, for example, the lungs or lymph node, how do you know if it's metastatic Pheo versus something else? Can other types of cancers light up on a dotatate scan?
So in terms of dotatate, it's very specific for neuroendocrine type tumors. So there are other types that are different from paraganglioma or Theochromocytoma that can take it up too. So other, just non-functioning neuroendocrine tumors, those in the pancreas can often take up. But, once it lights up in the area on the dotatate, we often combine it with a CT scan so you can really narrow it down to the specific site and area.
Dr. Nehs, I think you also have a comment on this. Tell us a little bit about the identification of these when they're outside of the standard location, the traditional locations.
Yeah, thank you very much, Dr. Rosen. So the first thing to do is establish the biochemical diagnosis, as was said earlier. So once you've done that, then assessing the architecture of where the tumor is located gives you some clue about what you're going to encounter and your surgical approach. So for me, when I see a tumor, for example, tomorrow, I'm operating on a tumor that is a para-aortic paraganglioma on the left para-aortic sympathetic chain. And so I have a sense on what its functionality is going to be. It's going to make norepinephrine. I look for lymph nodes in the surrounding region. If the tumors are very large or associated with more aggressive phenotypes, something like SDHB, where there may be advanced disease, I'll consider lymphadenectomy. Gallium dotatate is extremely helpful and very sensitive for neuroendocrine tumors. It's not specific for Theochromocytomas and Paragangliomas, but in the context of having a suspected or known Theochromocytoma or Paraganglioma, it is often indicative of metastatic disease if there are multiple foci, for example, in the liver or along the para-aortic chain. So that's kind of how I think about the nature of the workup, the metastases, extra-adrenal sites, and I really think through where is the disease located and what surgical approach am I going to need to clear it all, if that is in fact possible.
So I'm going to ask a follow-up question to that, and then Dr. Cartwright has a question for the group. This also was asked earlier, which is about genetic testing. So there's a difference between germline and somatic mutations. Germline are the kind that you can pass off, down to your family, somatic within the tumor. Let's start with Dr. Miller. Dr. Miller, you want to comment at all on when you perform testing for familial diseases and how important that is in your management to patients?
Testing for patients with known familial disease. So this is an interesting question that I think has changed over the years, and I know it was discussed on last year's webinar as well. And there is still, I think, debate among providers, although the guidelines essentially have shifted to recommendation of genetic testing in all patients with Theochromocytomas and Paragangliomas. The American Association of Endocrine Surgeons just came out with their new guidelines on adrenalectomy. So that's something that everyone can check out. That's in JAMA Surgery, and that is open access for everyone. I think Emily is going to put the link to that in the chat or on Facebook for everyone. But that would be a good resource. It does talk about adrenal disorders in general, but does touch on Pheochromocytoma and Paraganglioma. But there are a lot of, we work very closely with our genetic counselors. We have one embedded in our program at Ohio State, and I know many other programs around the country do as well. I personally find it, regardless of whether or not somebody has a family history, even in somebody who does not, I find it very valuable because I personally want to know that information up front before I do an operation. And mainly that gets to something that we'll probably talk about a little bit later, is planning your operation and whether or not to do a partial adrenalectomy on somebody, trying to save some of the cortex so that there is still production of steroids, of cortisol. And we can get into that a little bit later because there's lots to talk about with that. But I prefer it up front. It does take us several weeks. It used to take about 6 weeks to get those tests back. There's a gene panel. I won't name the company necessarily tonight, but there is a 38 gene panel that is very valuable. You can do single gene testing or you can do a panel. And if you come from a family who has a known mutation, then doing single gene testing is probably the way to go. If you have no familial history and you don't know what the mutation is that runs in the family, then having a panel run is probably the best thing to do. But I think it's important that people have this done. I think we used to debate about whether or not to do it in patients who presented when they were in their 60s or so, because you said, oh, if they got this far along, they probably don't have a mutation driving that. That's something that they would pass down to their family. But we do find them, and we used to think that Pheochromocytomas, we would say the rule of tens. And 10% bilateral, 10% genetic, 10% malignant. And those numbers have certainly changed in the last decade. And now we think up to potentially, I think now it's 30 to 40% may have some sort of genetic mutation driving this. So I think it's important for everyone. I talk to everyone about it, and I send them to the genetic counselor and allow the genetic counselor to go through the family history with the patient and help them make a decision as to whether or not that's the best thing to do. But now it only takes about 3 weeks to get those results back. And again, as we'll probably talk a little bit later about preoperative blockade for surgery, you need a couple of weeks, 2 to 3 weeks or so, to get people prepared for the operating room. So that to me is not a delay in time to the operating room anymore.
So a good follow-up to that question, Dr. Nehs. I'm sure when many patients are diagnosed with Theochromocytoma, they feel an urgency in getting to the operating room. Based on what Dr. Miller just said, you want to comment a little bit about your feelings about genetic testing and about preoperative preparation of the patients?
Yeah, absolutely. The most important thing to do is perform alpha blockade. So by far, that's the most urgent thing to do, particularly in the patients who present symptomatically in the emergency department with a crisis, catecholamine crisis, or if they have extreme catecholamine crisis, it can cause a rare but concerning heart problem called Takotsubo cardiomyopathy, and it's essentially heart failure. That can occur very rarely. Even in those patients, alpha blockade and control of the symptoms is step one. Because if you take a patient to the operating room without this alpha blockade, or in some cases beta blockade as well, you're manipulating the tumor during the operation, which can release tons of catecholamines into the system and elevate the blood pressure to a dangerous level. So we want to make sure that patients are prepared prior to surgery. That can include a variety of different ways to alpha block. There are many agents available, phenoxybenzamine or doxazosin, or a variety of other agents. And the way to do this is to start the medication relatively on the lower side of things to ease the body into this blockade. If you overdose initially, can cause all kinds of problems with your blood pressure falling too low. So what we're really trying to do is block the effects of catecholamines and prepare your body for the surge of catecholamines that can occur during the operation. This often takes 2 to 3 weeks to perform and should be done very closely monitored with your endocrinologist or your surgeon or whoever's prescribing this in preparation. We typically use doxazosin in our institution because it's relatively inexpensive and relatively easy to use and monitor. One side effect is nasal stuffiness. And we use nasal stuffiness as a gauge that we're doing a reasonable job in this way. And that's because there are alpha constrictor, there are alpha agonists in the blood vessels in your nose. And if you block those, it causes the nose to be stuffy. And so that's one method to know if you've made progress in that regard. The second is called orthostatic hypotension. It's like when you stand up and you get lightheaded, and this can be essentially from low blood pressure. And so those are two ways to know that a patient is roughly prepared for surgery and can undergo blockade. So those are the ways in which we typically do alpha blockade in preparation in our institution. We don't rush anybody off to the operating room until they're blocked.
So I had a kind of related question, Dr. Lyden. Is there ever a situation, or what are your thoughts on the possibility of not providing alpha blockade prior to going to surgery?
Yeah, people have done in surgery with calcium channel blockers and other things, but the safest, modality is probably what your endocrinologists are used to using, and so we typically also will use the doxazosin, the phenoxybenzamine. We used to use metyrapone, which worked very well, but has not been available as easily. And, there are other options, but the key thing is you don't want to rush into anything. Different patients take different times to get ready. And as Dr. Nehs had said, when you're ready for surgery is when you feel miserable. When you're stuffy and you're lightheaded when you stand up, that's when you're close to being ready.
And perhaps could I build on that a little bit on what Dr. Lyden is saying too? Is a very important point is you've got to have a good team of people who are skilled in this preparation. So it's helpful if the surgeon understands all the details. That's true. But the anesthesiologist, you've got to have an excellent anesthesia team. So some people do use calcium channel blockers just intraoperatively and IV alpha and beta blockade without preoperative alpha blockade. So there are many excellent surgeons who do that. We don't at our institution, but I think as long as you have a good trusted relationship with the anesthesia team, I think this surgery can be performed safely under those different conditions.
Dr. Jimenez?
Thank you very much. So yes, I agree with what has been said before. Just to comment a little bit more on the alpha blockade. The alpha blockade is very important because you are going to prevent complications because of the damage that the catecholamines may cause in different organs, and which are the organs that are going to be protected by the alpha blockade. Those organs are the brain, and the alpha blockade there may prevent strokes and hemorrhages. The lungs, and the alpha blockade may prevent pulmonary edema. The kidneys, and the alpha blockade may prevent kidney failure or renal insufficiency. The gastrointestinal tract and the alpha blockade may prevent ischemias, and the eyes, where the alpha blockades may prevent the retinal bleeding, for instance. So as a principle, in endocrinology, most patients with Theochromocytomas and sympathetic paragangliomas with tumors that are hormonally active, as indicated before, should be prescribed with alpha blockades. Believe it or not, in the US, there is one area that has determined recently which medication to prefer while using the alpha blockade, and it has to do with the price of the medications. Phenoxybenzaimine, for reasons that are not clear to me, despite of being a very old medication that was described more than 70 years ago, has a price of approximately $2,000 to $3,000 per month, and no many health insurances pay for that medication. Because of that, we are more of the tendency to use medications such as doxazosine or terazocine. Doxazosine and terazocine are selective alpha blockades, and by being selective, these medications have half-lives that are relatively short when compared with phenoxybenzaimine. For instance, the half-life of phenoxybenzaimine is 10 days. The half-life of terazocine and the half-life of doxazosine is 24 hours. There is another alpha blockade that is selective, which is prazosin, but prazosin is not the medication that we prefer to use because the half-life is very short. It's only 3 hours. So in general, we prefer to use terazocine and doxazocine. Now, if you look at the guidelines of the American Association of Endocrine Surgeons, the guidelines indicate that you can use in preparation for surgery phenoxybenzaimine or a selective alpha blocker such as doxazocine or terazocine. According to clinical trials that have evaluated both medications in comparison, phenoxybenzaimine may prevent more events during the time of surgery when compared with doxazocine or terazocine. However, phenoxybenzaimine is associated with a higher rate of post-operative hypotension. So it's up to you, the choice of this medication. As indicated before, we have to remember that every patient with Theochromocytoma and Paragonglioma is an individual and may be different from all the others. So the management should be individualized. And to add to this, please don't forget that beta blockage is also important. The beta blockage will protect the heart, and the beta blockage should be started once the alpha blockage has been achieved, which is when the patient has developed the orthostatic hypotension or the paroxysmal tachycardia in response to a very good hypotension caused by the alpha blockade. The beta blocker could be used in different ways, but medications such as propranolol, atenolol, or metoprolol could be indicated depending on each particular case. And yes, as indicated before, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers are medications that could also be effective in the preparation of patients for surgery.
So it certainly sounds like whenever anybody is diagnosed with a pheochromocytoma, that we have to be very careful, mindful of the medications we put them on, carefully prepare them for surgery. There are different options all over the US, and no rush in getting off to the operating room. Every T has to be crossed and every I has to be dotted for these patients. Dr. Cartwright, I think you have a couple more questions.
Yeah, kind of still on the topic of workup, is there ever and when would there ever be a situation for a biopsy? And let's see, Dr. Miller, could you address this question?
I'm actually going to punt to Dr. Lyden because I know she has certain feelings about this given some of the papers that have come out of her institution. So I'm going to let her talk about some of that data. I am not a fan of biopsying Pheos. So.
I am not a fan of biopsying Pheos either. So generally my philosophy is the only adrenal tumor that should be biopsied, generally speaking, would be if you suspect that you have metastatic disease to the adrenal from a different type of cancer. Biopsying a Theochromocytoma can be very dangerous. I've seen where people biopsied a Pheochromocytoma without doing a functional workup, which I think it's critical before any intervention that you exclude a Pheochromocytoma.
I don't have any data on this, but I do have an anecdote. A couple of years ago, I had a man who was referred to my office from another institution where he underwent a biopsy of an adrenal mass, and it caused a catecholamine surge. He went into a heart rhythm called VFib arrest, essentially cardiac arrest, during the biopsy. And he thankfully was resuscitated, but he had several rib fractures. And so he presented to my office with complaints about his rib fractures and his Pheochromocytoma. And for me, that was a very palpable experience to know what are the consequences of biopsying Pheochromocytomas, or what could it be?
So I'll add something to that, which I'm going to ask Dr. Jimenez to address, which is, are there situations in which patients you suspect have a malignancy or a malignant Pheochromocytoma before surgery? And are those patients appropriate to biopsy? And what are you looking for in the biopsy?
Well, the answer is the same as Dr. Nehs and Dr. Lyden answered before. Biopsies are contraindicated for Pheochromocytomas and Paragongliomas. In other words, the diagnosis of a Pheochromocytoma or a Paragonglioma should be made based on clinical features, biochemical studies, and radiographic findings. And all of them together should tell you exactly what the patient may have. As discussed before, the sensitivity of the plasma metanephrine is 99%. The sensitivity of a CT scan or an MRI for the characterization of an adrenal tumor, in this case, a Pheochromocytoma, or even for a Paragonglioma, an extraadrenal tumor, is higher than 95%, and the data type PET may offer you a sensitivity of 100%. In other words, with other testing, tests that are not invasive, you should be able to make the diagnosis of a Pheochromocytoma or a Paragonglioma before surgery, even if you have a disease that is broadly metastatic with clinical findings, radiographic studies, and of course, with evaluation of experts, you should be able to make the diagnosis before doing any biopsy. Biopsies in reality are contraindicated.
Well, I think we put that question pretty much to bed. One thing I think is important for everyone to know is there's a very big difference between biopsies and pathology. I get this question often from my patients. Biopsies usually remain, it's a portion, a small piece that you're taking. Technically, when we do surgery, we're doing excisional biopsies. We're removing the object and sending the whole specimen for pathology to look at it very careful under the microscope. But the word biopsy and pathology are often confused by our patients, so it's really important. Dr. Cartwright, I think you have a follow-up question on that.
Yeah, for Dr. Nehs, could you touch on how Sdh mutations are determined and whether or not they may alter surgery?
Yeah, for sure. So Sdh mutations, I think, are absolutely fascinating. SDH stands for succinate dehydrogenase. And succinate dehydrogenase is an enzyme, a complex in your mitochondria, the energy producing organelles of your body. And their job in life is to help create a gradient across your mitochondria. And there's several different variations in this mutation. There's 4 subunits, A, B, C, and D. And so probably many people who are listening tonight have different mutations in SDH. And those create different pheochromocytoma and paraganglioma syndromes. There's a lot of overlap among those different variants, but they do share some distinct features. So SDHB, for example, on average tends to be more abdominal paragangliomas. For example, I've got 2 patients recently who've had para-aortic paragangliomas with SDHB. I have a patient with an SDHC, and she had a paraganglioma that was next to the adrenal gland along the sympathetic chain, but not in it. And all of these only make norepinephrine or noradrenaline as opposed to adrenaline. And then some, the SDHD variations often are in the head and neck. And those can present skull base or carotid body, etc. So we have many patients with those. And to answer the question of why is it that the variation in that subunit produces the phenotype we see in the abdomen versus head and neck, I don't know the answer to that. But we definitely think through the nature of what is the inheritance, who else in the family has this, is this a de novo mutation, and then where do we expect the paraganglioma to be? Because that alters our surgical approach, our workup, and our surveillance.
There's so much to unpack in every one of these comments. I'm going to bring us back a little bit. We had talked about the preoperative preparation for patients for surgery. We touched a little bit on genetic workup, not only of the tumor itself, but germline, so familial inheritance of these. We haven't really yet talked about surgery or the surgical approach for patients. So, the thing I really enjoy hearing is how everyone who's presenting really thinks in terms of patients. Like you can think of a patient you've taken care of who has one of these diseases, and we all learn so much from each patient. Dr. Lyden, can you share with us a little bit about your thinking in patients who have tested positive for any of the familial mutations in terms of managing their pheochromocytoma? I know that's a big question, but take a piece that interests you.
Yeah, from a surgical standpoint, once you know it's familial, you know that the risk is there for having, potentially bilateral adrenal pheochromocytomas or paragangliomas in multiple locations. So number one, as we mentioned before, is localizing what you're dealing with and where it's at. And I am a very strong advocate for laparoscopic surgery when feasible. Paragangliomas can be done laparoscopically, as well as pheochromocytomas. If I am convinced it is malignant, then I do prefer an open approach from that standpoint. And laparoscopically can be done a lot of different ways. I do the majority of mine robotically. Others are transabdominal laparoscopic. People can do a posterior approach through the back. And the key way that it's done is what your surgeon is most comfortable with. And many of the, from a surgical standpoint, when it's done laparoscopically, most patients will go home within 24 hours. I've even had patients that had a great block and did super and went home the same day. And again, that's very patient dependent as well as surgeon dependent.
Dr. Nehs, I think you had some comments earlier on this one as well, and a question was asked about partial adrenalectomies.
Yeah, absolutely. This is a fascinating topic for all surgeons to talk about. What is the surgical approach? And so I agree completely with Dr. Lyden that most of these can be done laparoscopic, at least the pheochromocytomas and some of the paragangliomas. I will say, just from my experience, that a lot of the paragangliomas around the aorta or the aorta cable tend to be quite sticky during the operation. And so I tend to favor an open approach for those, just for good exposure, although I think it can be done robotically or laparoscopically as well. Sometimes if you have a syndrome where you have bilateral Theochromocytomas, or you're at least at predisposition for it, we have to think about the patient's future. So I have many young patients who are in their 20s or 30s, and they have bilateral Theochromocytomas, and they need a bilateral adrenalectomy. But that sets them up for the potential for long-term steroid dependence to be adrenally insufficient. And so one of my main goals of the operation is to, of course, get out the Theochromocytoma, but also leave them with enough adrenal cortex to keep them off of steroids. So the way I typically prefer to do this is I assess the size of both Theochromocytomas, if there are two, and I will often operate on the smaller one. And I will perform a cortical sparing approach. This is where I remove the tumor on the affected side and leave behind part of the adrenal cortex. And this can often be done by cutting partially through the adrenal gland. I performed this operation last week on a 37-year-old woman with NF1 mutation. And we performed a cortical sparing approach on the left side. I left behind the cortex, and I'm going to get a CT scan to assess the viability of that remnant. And then in about 3 weeks, I'm going to go back and take out the entirety of her right adrenal gland because it's the larger tumor and it is significantly involved, presumably with the cortex. And I don't think a cortical sparing approach will work. And so my strategy is really geared at two things simultaneously. First, cure the disease, but second, maintain steroid independence by preserving the adrenal cortex.
Dr. Miller, can you talk a bit about the guidelines for resection?
Sure, and this goes into the AAES guidelines that just came out, but also the Endocrine Society guidelines that have been out for a good number of years. And I think when we're looking at, people will ask questions of how do you know that a pheochromocytoma is benign or malignant? And that is hard to determine. I don't think the pathologist really can. I think we all say this, is that really the way that you know something is malignant when it comes to pheochromocytoma, paraganglioma, is that it is invading adjacent structures or invading into the fat or the kidney or the liver or something around that into the, it can travel into the blood vessels in rare cases, or it has metastasized somewhere else. Otherwise, I would say that most people don't present that way. And so we have to think about these as potentially malignant. I think we get more concerned the bigger the tumor gets. But you can see big benign ones. We have to think about resection as well in terms of not puncturing through the capsule or the covering of the tumor and spreading any little cells. Even benign tumors, if we do that, can recur locally. That's called Theochromocytomatosis, or that's what a lot of the surgeons call it, because we have something similar in the neck with the parathyroid glands that we call parathyromatosis. We're starting to see more and more of that. I think as laparoscopic surgery has come and been established for now probably a good 30 years or so. But those little micro perforations, as we're taking the tumor out, whether or not you do it laparoscopically or by an open means, or sometimes we do hand assisted, which is kind of in between the two. We have to be very careful about the way we take the tumor out, even if it's a benign tumor. But if we see evidence, the larger the size, the Endocrine Society guidelines say, as a tumor gets over about 6 centimeters, they worry about some of the technical ability to get those out safely. And if we see evidence of invasion, the AAES guidelines also will say if there's any concern for invasion, that an open approach would be indicated. I think also we have to think about genetic testing. So certainly with Sdh mutations, this is why I like to do genetic testing in advance, is to know what mutation somebody has. We can have other mutations that may suggest that they have other disease, that some of that disease can be in the abdomen, like in VHL patients. And so we may need to address those things at the same time. So we have to plan an operation around everything. But if I have somebody who's got an Sdh mutation, Those I'm going to probably want to do as an open approach because of the much higher potential for malignancy, to make sure that I get all the surrounding tissue and lymph nodes as well.
So along those lines, we have about 10 minutes left, and I have one question left, and Dr. Cartwright has a question left. So this question I'm going to ask Dr. Jimenez to address. In terms of numbers, how many patients are we really talking about in the US with malignant pheochromocytoma or Sdh mutations? And a follow-up to that question, which I think the panel can address, is if your paraganglioma was non-secreting to begin with, so for example, in the Sdh mutations, are other tumors also going to be non-secreting? How are you going to work up and follow these patients? Let's see if Dr. Jimenez can tackle that question first.
I will be brief. So the answer is this: Theochromocytomas and paragangliomas are an orphan disease. So the number of cases, new cases of pheochromocytomas and paragangliomas diagnosed in the US is approximately 1,000 cases per year. And of these 1,000 cases per year, approximately 100 to 200 are metastatic. Now, you will see in recent literature that we don't use more the terms malignant or benign. And the reason is because histologically speaking, it's impossible to differentiate in between tumors that are benign and tumors that are malignant. In other words, they look the same. So we use the terminology as metastatic and non-metastatic. So going back to the answer is approximately 100 to 200 are metastatic every year of the new cases, and 1,000 new cases of pheochromocytomas and paragangliomas happen in the US. Now, how many are Sdh positive? Well, Sdh positive are approximately 40 to 50% of those tumors that are metastatic. So you can make the calculations, and you may think that maybe 50 to 100 new cases of metastatic Sdh tumors may happen in the US every year.
Thank you. Dr. Nehs, do you want to comment a little bit more about monitoring these patients and evaluating them lifelong? Thank you, Dr. Jimenez.
Yeah, so all patients with Theochromocytomas, certainly the ones with inherited syndrome, should undergo surveillance. And that can be done in conjunction with your endocrinologist, or you can do it as the surgeon. And that's going to vary from region to region. Plasma metanephrines are very sensitive, 99% sensitivity and specificity, as Dr. Jimenez indicated earlier. So we find that that's a very useful way to monitor for recurrent disease. In some patients, we'll get CT scans or gallium dotatate or other scans, depending on the nature of the disease, especially if it's metastatic. So some of this will be customized according to your age, your mutational profile, and the burden of your disease.
Dr. Lyden, do you have I know that you have an additional comment. Can you add anything to that?
Yeah, I think the important thing is as time goes on, we know more and more of these are genetic. In the past, we thought only 10% may be heritable. But I think, as Dr. Nehs had said, these patients, need to be followed forever, whether or not your genetic screening is positive or not. You need close follow-up. And in terms of, there was the question of, if it was non-functional to start with, how do you follow up with those patients? In that case, you're basically stuck with imaging. It's worth doing the screening biochemically or with the blood or urine tests, but close follow-up with imaging will be important.
And just to emphasize on that part, if you look at the guidelines, consensus guidelines on how to follow on genetic syndromes, and they were published at Nature Endocrinology last year. In those guidelines, yes, radiographic studies become more important than the biochemical testing for the follow-up of any patient who had a predisposition to develop pheochromocytomas and paragangliomas. The reasons are several. You have mentioned already the fact that some tumors are not hormonally active, In other cases, the tumors are hormonally active, but they mainly produce dopamine, which is detected by measuring the levels of methoxythyramine, which is not easily available in the US, as well as many other countries around the world. And number three, you may see very little tumors that are hormonally active or will be hormonally active that initially will show plasma metanephrines or 24-hour urinary fractionated metanephrines that are not elevated, but radiographically speaking, you may find them. So the radiographic studies are a very important part of the follow-up of all these patients together with biochemical testing. And if you have to choose in between the two, please focus on the radiographic studies. Although in general, you will be able to do both, of course.
One difficult part of that, of course, is insurance coverage and access to care in the United States. It may be that many patients don't have access to genetic testing or don't have access to high volume endocrine surgeons or endocrinologists with expertise. Dr. Lyden, I believe you have another comment.
Yeah, I just wanted, when we were speaking about cortical sparing adrenalectomy, leaving a little bit of cortex behind. Just to be clear, that doesn't mean that there's not any of the medullary tissue or the tissue that has Theochromocytoma that can often be left behind as well. So there's still, close to even 20% or more may have recurrence in that remnant. So just because you may have had, both adrenal glands removed and a cortical sparing, you're still at risk and you still need the follow-up.
So as we approach the top of the hour, we'd like to thank our viewers and supporters for joining us this evening. A special thanks to our expert panelists for taking the time. We covered a lot of information, discussed Theochromocytoma and Paragongliomas. We also want to thank the Pheo Para Alliance for their support.
And I'd like to add to what Dr. Cartwright said. It's interesting as this conversation has gone on tonight, hearing from each panelist. It's all very formal tonight, but we know that we all have just so much more that we could comment on and think about. There's the data comes from patients. We think of things in terms of patients we take care of. Can't possibly capture everything in the short 1 hour that we have. So I would really like to thank each of the panelists, and we have 2 or 3 more minutes. If we could go through the panelists, if there's something you'd really like the participants to know, something interesting on the horizon, something they ought to think about in terms of themselves, their children and their families, in the care of patients, please add it now. We'll start with Dr. Miller.
Yeah, thank you. I just wanted to say, I know a lot of people struggle to find experts in this disease. Many of you are your own advocates, and keep being your own advocate. We are out here. You can find us. The Pheo Para Alliance is fantastic. It's been wonderful to partner with them. They have centers of excellence, which is actually a relatively rigorous application process for centers to go through. And so you can go to their website and you can look for the centers of excellence. The American Association of Endocrine Surgeons also has lots of information and a patient education portal at www.endocrinesurgery.org. We also have a surgeon finder tab. And so all of us in the AAES are high volume endocrine surgeons. So we have to apply to get into the AAES. So we are well-versed in Theochromocytoma and Paragonglioma. And many of us work in multidisciplinary teams, which is the other important aspect, is you need a team of providers from different specialties to take care of you.
I know Dr. Lyden has one last thought, and then I think we're at the end of our hour. Dr. Lyden?
I just want to say there's lots of hope. There's a lot of different things, coming up in the future, different ways of treating this. Most people can, have surgery that's curative, and you just need to have the follow-up. And I cannot underscore the importance of genetics and following up for those in your family as well.
We'll see if we can go 1 minute past. Dr. Nehs.
I'm grateful for my team, and I think if like maybe a captain of an airplane helps get the passengers to where they need to go, there's no way the captain flies a plane without the team. They need a co-pilot. They need all of the ground crew and the air traffic control. And so pheochromocytoma care is like that. We need the radiologists. We need the medical oncologists. We need the endocrinologist. We need the anesthesiologist with that expertise so that we can do the job that we love to do. So I'm grateful for my team, and I'm very grateful to know about the Pheo Para Alliance and be able to participate in events like this. Thank you so much.
And Dr. Jimenez rounding us out.
Just briefly, to everybody who has a pheochromocytoma and paraganglioma, remember that whenever the disease is not metastatic, the disease is curable. And for those patients who have metastatic disease, just think that these are new times, that there is hope, there is light, there is a new horizon with many novel therapies, and they are quite effective in clinical practice. And we are fortunate in the US to say that we have at least one FDA-approved medication and many other medications in clinical trials that are currently making a difference to several patients who have disease that is apparently not curable. I believe that someday we'll be able to cure patients who have metastatic disease.
So as a reminder, this session was recorded and will be available on the AAES Facebook page and on the AAES YouTube channel. For more information for patients, please be sure to visit AAES Patient Education website. Thank you again, everyone who logged in, and for all of our panelists.